Regional Center for Leadership in Healthcare Technology and Services.
WVIA presents an opportunity for viewers to confer with medical professionals about health-related topics. An opportunity for you to call the doctor. Here's your host, Paula Degnan.
Good morning and welcome to Call the Doctor. During February being Heart Month, along with many other things happening this month, we were taking a look at heart disease, and we've taken a look at the medical aspects of heart disease. This week on Call the Doctor, we're going to take a look at the surgical aspects of heart disease. So throughout our hour discussion, of course, we'll be asking if you have any questions that you'd like to ask our panel. We'll be welcoming your phone calls, and we'd like to introduce you to our panel members this morning, joining us in our discussion of a surgical look at heart disease. We'd like to say a very good morning and welcome today to Dr. George Cimochowski. Dr. Cimochowski, a specialist in cardiac surgery. Also joining us in our panel this morning, we say a very good morning to Dr. Kenneth Wilcox. Dr. Wilcox, also a specialist in cardiac surgery. And also joining us in our panel discussion today, Dr. Sam Hamzavi. And Dr. Hamzavi is also a specialist in cardiac surgery. And we remind our viewers this morning that if you have any questions you'd like to ask our panel, you can call us collect if you like at area code 717-655-5911. Remember, you don't have to be on the air live with your questions. You can give them to our operators, and they'll pass them along to our panel members this morning. And as we like to do to get to know our panel members just a little bit better, we'll start with Dr. Cimochowski. Thank you very much for joining us. And when we're talking about taking a surgical look at heart disease, are there a lot of new things that are happening? Maybe we could start by having you each explain a little bit about some of the new things that are happening, the new innovations.
Well, I think in cardiac surgery, it's true in most medicine, while the media occasionally thinks there's some outstanding advance, most of them are incremental. I think that's true in cardiac surgery. And I don't think in recent years there's any outstanding event. As Dr. Wilcox and I were talking before the show, we started using some warm, what we call warm heart surgery, which instead of cooling the heart when we operate, we're maintaining the heart at a normal temperature. And this is relatively new, and we think it's got some benefit. But I don't think there's any truly outstanding advances in the last year or so.
Okay, thank you for joining us, Dr. Cimochowski. Dr. Wilcox, Dr. Cimochowski set you up so nicely there. I'm going to ask maybe you could explain what the differences were in the cool and the hot, or the cool and the warm, as he was just telling us about.
Well, I'd have to refer back to Dr. Cimochowski for that, because he's the expert. This is something brand new. I think there's somebody, a surgeon, cardiac surgeon in Canada, that's been working with it for a few years. What we're talking about basically is the field of cardioplegia, which means cardio means heart, plegia means to stop or arrest the heart. In order for us to operate on the heart, it has to be not moving. It has to be a quiet, non-beating heart, and the blood circulation through the heart has to be stopped. And when you do that, then the heart is not receiving, the heart muscle is not receiving any blood supply, and so you have a limited time, amount of time in which to accomplish the surgery, and that's what makes cardiac surgery, I think, so demanding. And so for the last 20 years or so, people have been refining the methods of protecting the heart, putting it in sort of suspended animation. And traditionally what we do is cool the heart down and use a high potassium solution that arrests the heart and allows us to operate on it. And the metabolic rate of the heart is decreased by cooling it down, so it uses less oxygen. And now Dr. Cimochowski is talking about a new method by where we give blood that has high potassium in it, plus oxygen, so the heart is being oxygenated and remains warm, and yet it's arrested. So this is a unique concept. And it's interesting that he's using it at a community hospital here and has had some success with it. And this is the kind of thing that's usually begun in the university center and then spreads around. So I'm interested to find more about it.
Okay, well, maybe during our hour we'll see if we can extract that information from him. Thank you, Dr. Wilcox. Dr. Hamzavi, thank you for joining us as well. When we're talking about, I started off by asking about the new innovations of the surgical look at heart disease. What about when all of this started, Dr. Hamzavi, when cardiac surgery, you know, as we're talking, our panel members are talking about operating on the heart when it's not moving? Well, that to a lot of people is such a very scary concept, because if the heart's not moving, well, that must mean that the rest of us wouldn't be moving either. When did the surgical, when did all of this start, that you know, we're talking going back into the 1800s perhaps?
Yes. The heart surgery essentially came into being, the open heart surgery, that is, with the advent of cardiopulmonary bypass techniques. When you start a patient on the cardiopulmonary bypass, it means heart and lungs are at rest, and the rest of the body functions on the machine. That was the advent of it. As far as the new surgery is concerned and the old surgery, of course, in the old days, the congenital heart disease and valve replacements were most of the heart surgery. Right now, the coronary artery bypasses and surgery is the most prevalent as in majority of the cases. As far as the putting the heart in the resting position, I think the early days that we started, the heart, of course, was not completely in resting position, and we were not using cardioplegic solutions. And we cooled the heart as much as we could. That is some way to have the muscle not to deteriorate while you're operating. Nowadays, since we are cardiopleging the heart, the cooling is not as important as it was in the old days. But most surgeons, they cool the heart. But I assume that if you have a good cardioplegic solution and the heart is in resting, completely resting situation, probably you would not need to cool the heart. And this warm technique or normothermic technique probably is as good as any, because the cooling certainly does not have too much role to play.
Okay. It's a fact. I think everybody has at some point in time had someone that they've known who's had a cardiac bypass, or who's had you know, any other numerous things. So I think this morning's discussion will give everybody a very good insight into a lot more of those things before they have to be faced with them. We'd like to thank everyone for joining us this morning, especially our audience. Good morning and welcome. I'm Paula Degnan, and today on Call the Doctor, we are taking a look at a surgical look at heart disease, and we remind our viewers that if you have any questions you'd like to ask our panel, you can call us collect if you like at area code 717-655-5911, and you don't have to be on the air live with those questions. You can give them to our operators, and they in turn will pass them along to our panel members this morning. Dr. Cimochowski, I'm going to come back to you, and before we get into the hot and cold procedure, of which will now go down in every medical textbook as being the hot and cold procedure, when we were talking, we talked in a previous program about the medical aspects of heart disease, and when does a person get into the surgical aspect? You know, again, we talk about preventative medicine, which we always try to bring to light here on Call the Doctor, that if we could nip these things in the bud, that maybe we would never have to get into that. When do surgical procedures become necessary?
Well, I think there are three basic areas that cardiac surgeons work at, and that is congenital heart disease, in which a patient is born with some defect, either a hole in one side of the heart or another. Acquired valve disease, in which a valve is either congenitally malformed or develops something like rheumatic disease, and the valve eventually deteriorates to the point it needs replacement. And the third is coronary bypass, which is certainly the most common. The first, congenital heart disease, for the most part, there are very few medical treatments that can cure that problem. And in fact, to embellish a little bit on Dr. Hamzavi's comments, the first open heart procedure was done here in Pennsylvania at Jefferson Medical College. And I was fortunate to be a student under John Gibbon, who did that before I was a student. He did that in 1955, and actually he cured a young lady, I believe, from this area with an atrial septal defect, which is, if you want to look at this little defect, this is the right side of the heart, and there was a hole right here communicating with the left side of the heart, and he repaired that successfully. So I think congenital heart disease is pretty much treated surgically for cure. Mm-hmm. Acquired heart disease, acquired valvular disease is most commonly used to be a rheumatic disease, in which the valves progressively deteriorate, both the aortic valve, which is the valve here, the mitral valve lower down, and the valves narrow and calcify, turn to bone. And for the most part, you see in front of me here some valves I brought. These valves certainly work, but they're not as good as the human valve. And so surgeons are usually called in after the valve is deteriorated to a point where a conservative medical therapy no longer works. And in fact, much of the first heart surgery, as Dr. Hamzavi said, was done with valves. And unfortunately, the mortality rate was very high because our fellow cardiologists and internists didn't refer the patients to their near dead because the mortality rate with heart surgery was so high back then. Nowadays, we get referred sooner, but we still are reluctant to operate on early valve disease. The last category is coronary artery disease, in which sometimes with a single vessel disease in which a balloon dilatation has failed, we may operate on it. In other cases, the patient, and usually in other cases, the patient has three vessel disease, there may be some damage to the heart, and then we're asked to operate.
Okay.
So it depends on the type of problem that you have.
A lot of different circumstances that could surround it. All right, this morning on Call the Doctor, we're taking a surgical look at heart disease, and we'd like to welcome a caller to the program. Hi there, good morning, and welcome to Call the Doctor.
Good morning.
Would you like to ask your question to our panel?
Yes, I would.
Sure, go ahead.
I have my aortic valve is a bivalve instead of a trivalve, and it has started regurgitating, leaking back, and I would like to know, after this starts, it's been about a year and a half, is there a certain length of time about that you have to have surgery on it? I've also had endocarditis.
Okay, I think Dr. Hamzavi is starting to nod his head down there.
Well, the answer to that question is that the bicuspid aortic valves are a congenital anomaly that occurs, but it is common. And a lot of aortic valves that deteriorate are of this variety. This is not the only aortic valves that deteriorate. One would encounter a stenosis, which is narrowing of the valve more often than regurgitation on these valves. But when regurgitation occurs, we grade it on the 1 to 4 plus. And usually, if somebody has up to 3 plus regurgitation and is symptomatic, has symptoms, gets shortness of breath, gets symptoms like the operation is advised. One thing that I should mention, that when the time comes, procrastination on the regurgitation is not good. That if the ventricle, the pumping chamber of the heart deteriorates, usually that does not improve with the valve surgery. So when the time comes and the surgery is necessary, it ought to be done rather than procrastinating.
Okay. Thank you very much for calling this morning.
Thank you.
Bye-bye. Dr. Hamzavi, what would have caused that? As Dr. Cimochowski was mentioning before, you know, the different reasons that someone may be going into surgery. Would that have been something perhaps congenital?
Yes, the bicuspid aortic valve is an anomaly that happens often. The usual aortic valve has 3 cusps. The people who have 2 cusps, usually it's a little bit thicker, and the movement of the cusps are limited because of just the way they locate on the anatomy.
Okay, Dr. Wilcox, when we're talking about congenital problems like this, is there a way that a person would know, say our caller, that, you know, now obviously she's a little bit older, would there have been a way that she would have known this was going to happen younger in life? Is there a heredity factor in there too?
With this particular anomaly, not necessarily. A family physician or pediatrician or internist may have listened to the heart and picked up an abnormal murmur, which might occur with in a bicuspid valve, and then further studies could have been done. But usually people are not aware of this until they become symptomatic. In other words, they are short of breath, their exercise tolerance is limited, and at that point medical investigations are done and the patient is referred to a cardiologist. And but that's not a problem if they didn't know about it, because usually nothing is necessary surgically. No intervention is necessary until the patient becomes symptomatic. But as Dr. Hamzavi mentioned, once the patient becomes symptomatic, if one were to procrastinate too long, then what happens is the functioning of the chamber, main pumping chamber of the heart can deteriorate, and the results of surgery may not be as good as if it had been done at an earlier time.
Okay, so again, we'll get back into the surgery aspect of it too. Surgery is not always a definitive as well. There may be other factors involved there too, and we'll get into those in just a little bit. But first, we have another caller on the line. Good morning, and welcome to Call the Doctor.
How do you do?
Good. How are you this morning?
Good.
Good.
Now, I wanted to ask a question concerning, I have a nephew who was born with a bad valve. I think it was called aortic stenosis. And,
Aortic stenosis?
Yeah.
Okay.
And I
We're
believe...
having a little bit of problem hearing you, so maybe you could just speak up a little bit.
Yeah.
Okay.
And I was wondering, now he's been having some pain in his arms and stuff, and when he would be advisable for him to have this here operation done.
Okay.
What time?
All right. I'm going to start. Dr. Cimochowski, are you familiar with aortic stenosis? Perhaps we
yes.
could.
I missed the first part of the statement. Did you say his son?
Nephew.
No, his nephew.
Nephew. How old is he?
I'd say he's about 28.
28.
And he's starting to have chest pain, or arm pain.
Arm pain, I think it was.
Well, he's having both.
Well, what happens is there are two things that happen commonly, and that is because the blood cannot get out of the left ventricle here to the aorta here, because the valve between the two is narrowed, the left ventricle, which is the main pumping chamber of the heart, hypertrophies, and it enlarges because it's constantly trying to squeeze blood out through a narrow valve. And in fact, in aortic stenosis, the valve continues to narrow. So the heart enlarges. The other problem that happens is much of the blood supply that comes out of the aorta goes back to the enlarged muscle of the left ventricle. And so there becomes an imbalance, and so there's very little reserve. Not enough blood is getting out of the aorta, and much of it is demanded back for the left ventricle. So that when the patient tries to do a little extra work, for instance, then the heart muscle is deprived of blood because the blood has to go, say, to the legs, the walking or running. And then this is described by the patient as chest pain or angina. That's one of the three critical symptoms that a patient should be seriously considered for valve replacement. The other two are fainting and irregular rhythms caused by the heart not pumping sufficiently.
Okay,
so I think his nephew should be seriously considered for valve replacement if, in fact, that's what he has, is aortic stenosis.
Now, is that unusual for a 28-year-old?
No. It could very well be he had a congenital bicuspid valve, which is very common, and many people die with it without any symptoms. And other people, however, because the flow is slightly irregular, the valve leaflets, which are very delicate. And I wonder if they could just focus on this.
Yeah, I think we just hold that up just a little bit. There we go.
This is,
We'll come in there. There it
you
is.
can get a little closer. You can see how delicate the leaflets are. And this is from a pig. But the human valve is very much the same. And instead of being very delicate like this, the leaflets actually turn to bone. And so it is advisable then to consider replacing it and opening up that valve.
Okay, Dr. Hamzavi?
I would have to add that the symptoms only bring the patient for final studies, which is cardiac catheterization. Essentially, the area of the valve is measured at the catheterization, and that's what determines that the patient needs surgery or does not need surgery. There's two factors: the gradient across the valve, the difference in pressure on both sides of the valve, and also the valve area. Usually, if there is a 15 millimeter of mercury or more of the gradient across the valve, that is considered to be significant for an operation. However, we have had some children that they have that, but we wait until they get larger for an operation. Usually in children, you temporize until the aorta gets to the normal adult size before you operate on their aortic valve. But this gentleman, apparently 28 years old, probably has reached a full-size aorta, and if he has enough gradient, should be operated on.
Okay. Thank you very much for calling this morning.
Thank you.
Bye-bye. As we're talking about the different surgical procedures, one of our viewers from Taylor this morning, good morning to Taylor, brings up an interesting question, wondering about the fact that our caller had bypass surgery 10 years ago. And Dr. Wilcox, perhaps we can start by having you explain just what bypass surgery is. And the interesting part is she's wondering whether the bypass surgery is still good after 10 years. Once it's done, is it done, or do you have to go back for, as our caller says, is the warranty up?
Well, these are very good questions that we're frequently asked. And if we just look at the model of the heart, and I'll explain what bypass surgery is. Coronary bypass surgery means bypassing the coronary arteries, and the arteries sit on the surface, what we call the epicardial surface of the heart, and so they're usually easily visible. Then they send branches down into the heart muscle and supply the heart muscle with oxygenated blood. And when these arteries become blocked, then then the blood supply is diminished to the heart muscle, and the patient can feel chest pain. And if the blockage is sudden and complete, some of the heart muscle can actually die, and that's what we refer to as a myocardial infarction or heart attack. Now, when a patient presents with symptoms of inadequate blood supply to the heart muscle, the patient is usually referred to a cardiologist who performs a cardiac catheterization and injects dye into these arteries and gives us a roadmap with respect to the arteries on the surface of the heart, the anatomy, and where the blockages are. And if the conditions are favorable, then bypass surgery is recommended and performed. And bypass surgery is simply a plumbing job. We simply, conceptually, it's quite easy to understand. We simply bypass the blocked arteries with usually a piece of vein taken from the leg. The vein goes from we plug one end into the aorta, this large blood vessel coming out of the heart, and the other end is plugged in to the coronary artery beyond the blockage, and we simply bridge over this blocked artery and bring new blood supply to the heart muscle, which makes it a happier heart. Now, the question was, the patient had heart surgery 10 years ago. How long is it going to last? Well, unfortunately, we've found over the years that the vein grafts do not stay open forever. And there's a certain attrition rate which varies from individual to individual. And it's very difficult to predict in any given individual how long that vein graft will last. What happens, the vein graft becomes diseased just as the arteries in the heart become diseased. And the average lifespan for a given vein graft from the heart may be, well, let's put it another way. After about 10 years, they find that about half of the grafts that were placed on a heart are blocked. But now we're using something else called the internal mammary artery, which has a much longer lifespan. Unfortunately, the mammary artery, we can only use it for 1 or 2 bypasses. And but we usually use it for the most important artery on the front of the heart, called the left anterior descending, the LAD. And we found now that with the use of the mammary artery in combination with vein grafts, that the survival rates are longer, and we're less likely to have to reoperate on the patient. Now, with this particular caller, the surgery was done 10 years ago. It's I would say probable that they did not use a mammary artery in that situation. But for any given situation, it's almost impossible to predict how long the veins are going to stay open. It's highly variable. If the patient begins to get recurrent symptoms of chest pain that are uncontrollable, then the cardiologist will investigate this and may do another cardiac catheterization to see if the vein grafts are open. If the patient's having no symptoms and feels fine, then don't worry about it.
And we're talking about blocked arteries, and we have another question on that to follow up in just a moment. But first, we'd like to welcome another caller to the program. Good morning, and welcome to Call the Doctor.
Hello.
Hi there. How are you today?
Fine. How are you?
Good, good. What's your question this morning?
Okay, it's about my husband.
Okay.
Okay, he seems to be having a lot of burning. Now, we've had several tests, stress tests, the thallium stress test and all done, and they don't seem to come up with any answers about the heart. I was just curious as if they feel that maybe catheterization or something should be performed.
Okay, how old's your husband?
Pardon me?
How old is he?
He's 35.
35.
And the burning it's right in the, like right around the heart. I guess they called it the chest muscle or the chest cavity.
Okay.
And that's where he seems to be having the problem.
All right. Dr. Hamzavi, first I'm going to ask you to explain. She mentioned, and we've heard this a few times from our panel members, cardiac catheterization. Perhaps you could explain what that is first.
Yes, well, to be relevant to this lady's question, the chest pain essentially has many, many causes. It does not have necessarily to be due to the heart. The interthoracic structures, the esophagus, which is a food pipe, stomach, the lungs, the structures, all could chest wall, all could create pain. If I hear that the thallium stress test was negative, then probably the cardiologist has to really decide that if he has a typical angina which relates to the heart, to do the cardiac catheterization. I believe that there's an indication for cardiac catheterization in somebody with a negative stress testing, the stress thallium, if the pain pattern follows some activity pattern or follows patterns that are suspicious of being the heart related pain. Your question, there was the second thing you were...
I was wondering what cardiac catheterization meant.
The cardiac catheterization essentially is that a catheter is inserted through an artery or vein into the heart to measure the pressure and take some pictures with the injection of the dye. The veins are used to catheterize the right side of the heart, and the arteries peripherally are used to insert the catheter to investigate the left side of the heart, if you hear the left or right heart catheterization. And essentially, you can make all the heart diagnoses by the use of the catheter.
So in this case, then, would I guess our caller is wondering, is it necessary to go to that next step after?
I think if the chest pain is typical of the angina pectoris related to heart, probably, but otherwise not.
Okay. Thank you very much for calling this morning. Yes, thank you. Okay, bye-bye. Well, we were talking about the bypass surgery. I'm going to come back to Dr. Cimochowski and ask you now. Our caller was wondering when a bypass was concerned as far as clearing out the blockages by using bypass surgery. Well, since I asked you in the very beginning about the new innovations in surgical techniques as far as heart disease is concerned, what about our friend the laser? We hear that in so many other aspects of medicine, and we hear it, all the time. Is this one of those cases that maybe it's going to be there someday?
Well, let me explain more clearly about bypass surgery. We don't disturb, usually, the disease that's present. We go around it, specifically because we want to operate and put the bypass graft into an artery where there's free of disease. And that way it stays open longer and has a better flow. Our medical colleagues, the cardiologists, have approached it somewhat differently. They have tried to approach the block itself. And as you're hinting at, there are multiple ways of doing that. The initial one was to take a balloon and dilate it. And then they went on to develop what some people refer to as a rotor-rooter, cutting the disease out, and most recently has been the laser. Now, the problem with all three of these is that they all recur at the site of the disease, which is pretty much why surgeons historically have stayed away from it, because we learned when we clean out the disease site, it often recurs there. What's most interesting about it is they all recur with about the same rate of recurrence at the site, whether it was dilated with a balloon, whether it was cut out with a rotor-rooter, or whether a laser was done, and the recurrence is not the same problem as the original problem. The recurrence is really an injury recurrence, and it's scar tissue. So now we've replaced the atherosclerotic, the hardening of the artery disease block with a injury problem. So to date, I think most cardiologists and surgeons are somewhat conservative about the long-term outlook of the current technology. There's no question in a certain number of individuals it works beautifully, but a significant number of patients, disease recurs, and it recurs with this scar tissue.
Just like anything else, everything depends on the person. This morning on Call the Doctor, we would like to take a moment right now to introduce you or reintroduce you to our panel members this morning. Joining us in our topic today of a surgical look at heart disease, we say a very good morning to Dr. George Cimochowski. Also joining us in our panel discussion this morning, we welcome Dr. Kenneth Wilcox. And also on our discussion this morning, Dr. Sam Hamzavi. And we remind you that throughout the remainder of our program, if you have any questions you'd like to ask our panel, you don't have to be on the air with those questions, but you can call us if you like. Collect at area code 717-655-5911. Can be on the air or just give them to our operators and they'll pass those questions along to our panel. And speaking of questions, we'd like to hear from you and not only your questions, but perhaps suggestions. And if you have a topic suggestion or maybe a follow-up question to one of the shows you've seen previously here on Call the Doctor, you can write us a letter or a note or whatever you may decide, and you can mail that off to Call the Doctor, WVIA TV, 70 Old Boston Road, Pittston, Pennsylvania, and the zip code is 18640. And we certainly like to hear from you. And if you'd like a response on that, make sure you include your address so we can get back to you. And we're going to get back to our discussion today. We're taking a surgical look at heart disease. I'm Paula Degnan. And as we're talking about this, Dr. Wilcox, since you have the model in front of you, as we've been pointing out, we've been using various, where exactly does the heart fit? Now, is that the upright? Because now it's after Valentine's Day, and there have been a lot of those little red hearts that have been flying all over the place. So this is the actual model of a heart. How exactly what you've been talking about, the valves, are they actually, is that the right position it's supposed to be in?
Well, first of all, this is Dr. Cimochowski's model. It was a good idea of him to bring this in.
I thought you were going to say it was his heart, I was going to say.
So that was very thoughtful of him to bring it in. The heart would be located in the chest something like this, so that this is the apex of the heart pointing into the left chest, so it's slightly to the left of the midline. And these are the, what you see here would be the right ventricle, this bump here, and the left ventricle. And the right ventricle receives blood, dark venous blood, that's been deoxygenated from the rest of the body. And the deoxygenated blood comes into the veins, the inferior vena cava, superior vena cava, and into the right atrium, and then into the right ventricle, and then out the pulmonary artery, and then into the lungs. Now, you're all going to be tested on this later, so I want you to pay attention. And then, after the blood circulates through the lungs, it becomes oxygenated red blood, and it enters the left atrium over here through these red vessels here, and then into the left ventricle, which is the strongest, most powerful pumping chamber of the heart. And this blood is ejected out of the heart with great force into the aorta, and the aorta sends branches here to the head, to the neck and the head and the arms, and then the aorta continues down through the back and continues to send branches to the rest of the body. So the heart generates the blood circulation for the entire body, and obviously the entire body is absolutely dependent on the moment-to-moment functioning of the heart. Within the heart are one-way valves that prevent allow the blood to go in one direction and prevent egress of the blood in the wrong direction, the opposite direction. Let's see, how can we show those in here?
Well, I'm glad you brought the valves up, because now I want Dr. Cimochowski to show his valves that he brought with us and explain maybe where they go, because as we've been talking about the surgical procedure, and he did show us the valve he had up a moment ago, it's a very small area that you're dealing with. So now, are these that you have in front of you, Dr. Cimochowski, are they actual to go in a person's body? Now that, I think, you told me that's a valve, but I think that's really just a golf ball that maybe you got a...
It's a golf ball.
It's a golf ball that you got a hole in one with, so you decided to just save it.
Actually, this obviously is just a floor model. It's called a caged ball valve, and it was first designed by Dr. Starr who's currently in Seattle, and it's called the Starr-Edwards valve. Edwards was the engineer who developed this. And it works basically by, it sits in the surface of the heart is down below it, like this. And when the heart contracts, it pushes the valve forward, blood comes out around the sides of the valve, and on the next beat when the heart fills, the ball valve comes down, so no blood comes back into the heart, and the heart fills normally from the lungs.
Now, why would someone need to have that particular?
Well, the gentleman who called about aortic stenosis, if the valve area is so narrow that it can't push out. And the other most common thing is if the valve is incompetent, that is these leaflets. This is really a very sort of typical, they could focus in on here again.
It's a little teeny tiny.
Yeah.
There we go.
You'd be looking at the valve from outside the heart looking back in. And as the heart beats, it would push open this valve like this, and the valve would open up, and blood would come out, and then as the heart relaxed and filled up, the valve would close like that. So sometimes patients whose valve is open and then closes, like I believe the woman called about her husband, the valve leaflets don't close properly, and one of them may stay open partly like this. You can see that. Maybe it stays open partly, and so blood regurgitates back into the heart. So now the heart gets what we call an overload, a volume overload. It has its normal blood coming into it from the lungs, and then some of it regurgitates. And those are the most common reasons. Now, this is a pig valve. This was taken out of a dead pig and preserved with tanning solution, basically. And the strut here is man-made. These valves here, if we can focus on this one, maybe this one.
There we go.
Here we go. The black stuff, which is a little hard to see. I wonder if I could have the blue sheet here, the blue paper.
Yeah.
Could you get in a little closer?
There we go.
Yeah, there are leaflets inside, much like a hurricane cellar, something like that. And they open and close with the heart beating. And I don't know if you can see that here. These are very fine leaflets. They're made of pyrrolite, which is essentially the stuff that's on the front of a nose cone. It does not wear out. And then this ring around here is soft material, and that's where we put sutures in to hold it in place in the heart. And this is a little different version. This is instead of having two leaflets, has one leaflet, which opens and closes with each heartbeat. That's called a Medtronic Hall, which we're just starting to use more frequently now. The pig valve, and then the Starr-Edwards. And while this isn't as frequently used, this golf ball mechanism here, this is the oldest and the most successful. And there are patients who have had this put in 30 years ago, and which is working perfectly normal and may have beat 2 or 3 billion times.
Now, while you're talking about that, one of our viewers this morning is wondering about which, and I guess this is kind of, yeah, he knows the question, which one is better then? Which one is going to be lasting longer? And the one that is mentioned here in our question is a St. Jude mechanical valve?
Yes. This is the St. Jude mechanical valve, this sort of trapdoor valve here. In my opinion, and my colleagues can certainly comment on it, the data doesn't suggest that one is superior to the other. There are certain instances in which we prefer one. Certainly, the pig valve is a little inferior in the sense of longevity. This does not last nearly as long as these three valves because these fine leaflets, and I think you can even see there yourself, they tear. And this valve fails about 40% of the time after 10 years. Whereas I just mentioned this valve has been in place in some patients for 30 years, as well as these valves have been in place. This has been used for 12 years, the St. Jude. Medtronic Hall has been in for about 15 years. So these, what we call mechanical valves, last longer and do not wear out, whereas the pig valve wears out. On the other hand, if you have a normal rhythm, and let's say you're a young lady about 35 and you have a congenital valve problem and you still wish to get pregnant, then we would put in the pig valve because the pig valve does not require a blood thinner called Coumadin. And when you take the blood thinner, you're prone to bleed. And so if you're going to have a pregnancy, you may lose the baby if that's so. So we would prefer to put in a pig valve. And however, like in young people, this fails at an accelerated rate. On the other hand, in patients over 70, we don't like to put them on blood thinners necessarily. And so we would use this valve because most likely the longevity is such that they may not live to 90. not necessary to put in one of these, and at the same time, we don't have to use the Coumadin.
Okay, we have a caller on the line, but very quickly, I'd like to ask Dr. Hamzavi, as we're talking about all these valves, is there a chance for rejection? Like you might think about the fact that maybe because these are man-made as opposed to the pig valve, which is maybe more close to the human?
Well, the rejections essentially on these materials that do not exist. The prosthetic material, the Dicron and the carbon disc is not antigenic, so it's not going to cause any rejection. As far as the pig valve, it is not live tissue. It's a fixed tissue. And what happens to the pig valve in a younger people, there's some body reaction to it. As the age goes up, the reaction gets less. So in children, usually pig valve has not worked well. In middle age also, their result has not been that good, but after 65 or 70, usually there's no reaction to it, and it works very well. The reason that we would be using the pig valve, if we are thinking of a blood thinner and older people, they have bleeding problems, usually from bowels, from different areas, that we would like to use the pig valve. Above 70, usually for the aortic valve is mostly routine, we use the pig valve, unless some patient objects to it, that as a matter of not wanting something that might fail after 10, 15 years.
Okay. This morning on Call the Doctor, we're taking a surgical look at heart disease, and we'd like to welcome another caller to the program. Hi there. Good morning, and welcome to Call the Doctor.
Hi, this is Arlene.
Hi, Arlene. How are you today?
Good.
Good. What's your question?
My husband has had bypass surgery twice, and he's having real problems again. And the doctor said that they didn't think a third operation is very good.
Okay. I'm looking right at Dr. Wilcox, since he's the one who started the discussion on the bypass. Now, here's one who is having a problem, and we've gone, what was the time span in between the surgeries, Arlene?
He had the first one in 74, and then 15 years later he had another one.
And now he's having problems again?
Yes.
Okay. Dr. Wilcox, would you care to comment on that?
That's also another, that's a difficult question.
That's why we gave it to you.
That's why he gave it to me. Certainly, it's possible to operate on the heart a third time. For a third time, that would be the second redo operation. There's more risk involved because of the scar tissue that's always there, and the anatomy of the arteries that need bypassing in the heart may not be optimal for bypassing. So when the physician made the statement that it was not a good idea, to agree with him or not, I would have to have more data. Was another cardiac catheterization done to look at the anatomy of the heart to see if a third heart surgery was feasible or not? I'd have to ask the viewer whether that was done.
No, they didn't do another one because they said that as long as he didn't, they couldn't do the surgery, they didn't think they should do that.
Well, I'd have to know a little bit more about the history of the situation, what kind of symptoms your husband was having, how severe they were, if they were controlled with medications or not, whether or not he'd had previous complications related to the heart surgery, whether or not the heart muscle had been damaged significantly by a previous heart attack or a previous surgery, and the age of your husband. Those are the kinds of things we have to weigh in the balance. So I cannot absolutely say that he should or should not have surgery. We have to recognize that the third time around the risks are higher, and we have to weigh the potential benefits of surgery against the risks, and so we have to have a lot more information. I can only say that we have done that. All of us in this panel, I'm sure, have operated the third time around, and it's been done successfully, but we have to know more information before we can make that judgment.
Okay, Dr. Cimochowski, you wanted to make a comment?
Yes. I think one of the issues is whether the patient has had in the past simply vein bypasses, or has there been artery used, as Dr. Wilcox referred to earlier. And if the arteries have not been used, then I think it's much more feasible to consider reoperating. because the arteries are much superior for longevity. They would most likely last longer than the veins previously. And in my experience, when you're doing a third reoperation, it may not be necessary to do 4 or 5 bypass grafts. Sometimes 2 or 3 are satisfactory. And we can use the intramammary artery from the left chest, one from the right chest, and now we're taking, as Dr. Wilcox and Dr. Hamzavi do too, I'm sure, we're taking an artery from the stomach wall and using that. So we can get 3 arterial grafts. And if the patient is a relatively young patient, then I think that it's not out of the question.
Okay. Thank you very much for calling this morning, Arlene.
Thank you very much.
Okay, bye-bye. Dr. Hamzavi, when we're talking about taking arteries and using them for different procedures, how do you know that the artery that you're taking is going to be good, in good condition? Is there a way you can tell?
Yes. As it was mentioned, there are 3 arteries that are accessible for use for coronary bypass surgery. Right internal mammary, left internal mammary, and a gastroepiploic artery, which is in the upper stomach, is not needed for the stomach and can be used. The arteries are live graft. The veins are not live graft. They are detached from the body and reimplanted. So the difference is that the arterial bypasses, they last much longer. And historically, investigation has been done on the internal mammaries. They usually don't get plaques. Those are not the arteries that they get plaques. In most, almost 99% of the cases, they are usable and they're open. And gastroepiploic, however, it has a slightly lower rate. You could get arteriosclerotic changes at the beginning of the arteries, but that is also usable over 90% of the cases. So these arteries are usable, they are live grafts, and they should last much longer. Now, the callers must know that most times the coronary arteries are getting diseased beyond the graft. That's why the grafts are not working, not because the grafts close, but distal to the graft, beyond the graft, you get additional obstruction. Most of my patients that we have had to redo operation on them, they have not watched their risk factors. Some they've been smoking still. Some they've been gaining weight or maintaining a great weight. Sometimes they have not followed their diet. And these are the things that for a bypass surgery to last longer, you have to follow reduction of your risk factors completely before you're considered to have a second surgery or something like that. I think that has to be worked on.
When, as Dr. Cimochowski was showing us the different valves, that was what that's exactly what I was thinking was when we talk about cholesterol, when we talk about blockages of the arteries, you can really get a good idea as to how tiny these things are that we all have in our bodies and in our hearts, and how easy it would be for them to become blocked and damaged because of the things that we're taking in. So as you said, Dr. Hamzavi, if you're still doing that, what's not to make something that you put in there block up again, just like something that we already have in our bodies block up. So you really have to follow up.
And to comment, most patients that they follow their risk factors, you do not see them for second-time surgery. Mostly are the people that they have not followed their advice for the reduction of risk factors.
Okay, and then I hope that everybody was paying attention to that out there now, too. This morning on Call the Doctor, a surgical look at heart disease and another caller. Good morning and welcome to Call the Doctor.
Good morning.
Hi there.
My name is Mrs. Thornton, and the question I wanted to ask is exactly what is congestive heart failure, and will surgery help that condition?
Okay, Mrs. Thornton, I got what is congestive heart failure?
Yes. And
Okay.
will surgery help that condition?
Would surgery help?
Dr. Wilcox, since you heard the question, we'll let you take that.
Well, that's a broad and general question and doesn't have either a yes or a no answer. Congestive heart failure means that the heart is failing. The pumping mechanism of the heart has become weakened, and there are different types of congestive heart failure with different causes, and some of the causes may be amenable to surgery and some may not, so it's impossible to answer that question. definitively unless I know what the cause of the type of congestive heart failure is. It may be due to an abnormal valve that can be repaired or replaced, and the heart failure may get better in that case, or it may not. It may be related to inadequate blood supply to the heart due to blockage in the coronary arteries, and that may be amenable to bypass surgery. Or if none of those things are possible, a heart transplant could be considered under if all the conditions were just right.
Would any of these congestive heart failures cause the body to retain a lot of fluid, especially the lungs, when you're suffering from it?
Absolutely. That's the main pathophysiology, so to speak, the symptoms that and signs that occur with failing heart are related to fluid backing up into the lungs and the rest of the body because the pumping mechanism of the heart has become weak. So that's certainly a sign of congestive heart failure.
Okay, Mrs. Thornton, thank you very much for calling this morning.
Thank you.
Bye-bye. And a reminder, this morning on Call the Doctor, we are taking a surgical look at heart disease, and if you have any questions you'd like to ask our panel, you can give us a call. You don't have to be on the air live. You can just give them to our operators, and they in turn will pass them along to us. And we have quite a few questions this morning, and a lot of them just go back to, I think, a lot of things that as Dr. Hamzavi was mentioning, as far as prevention and taking a look at prevention before we get to the point. But when you're talking about, Dr. Cimochowski, when you talk about having a heart attack, and I think a lot of times people will let things go and unfortunately continue to smoke, continue to take things into their body that might not be that good for them even after they've had surgical procedures done. But until you have that heart attack and realize just how vulnerable you can be, that's when they start really taking care of themselves. If a person has a heart attack, and I also have a few questions here on silent heart attacks, does that damage the heart being a muscle? Can that, I guess people are thinking, you know, you have these things, the heart's going to stop, now it's going to have to pump harder. Can that cause more damage?
Yes. I think maybe just a word about what is a heart attack.
Yes, good idea.
A heart attack is basically when one of the arteries to a certain part of the heart, which is basically muscle, is blocked, acutely usually. And so suddenly the muscle no longer gets blood, and within a few minutes the changes start occurring, and it's pretty much confirmed that at least by 6 hours the muscle is so damaged that most of the time it will not survive. So the first point is that when you think you're having a heart attack, it's not a good idea to wish it well, but to call your family physician or your cardiologist or internist or the emergency room before 6 hours. The reason is that most blocks are caused by a clot, and that clot can be dissolved currently by streptokinase or TPA or one of the modern drugs that will quickly dissolve it within minutes. Blood supply returns to the muscle may swell, you may get some decreased function for a few days or even weeks, and it's possible to have a major heart attack, reverse it within 6 hours, and have no muscle damage. On the other side of the coin, however, is if the muscle goes beyond 6 hours without sufficient blood supply, either by the medicine or sometimes even by surgery, then the muscle will eventually die and it scars. If it scars what we call full thickness, and I might just show this again, I'm going to take a focus in here. The wall is a certain width, and when you have a heart attack, the inside wall dies first, and we call that a subendocardial, and often that's a mild heart attack, but it usually tells you that you're going to have a major one. Something should be done. Full thickness heart attack means the wall scars full thickness, and then whether we give TPA or whether you change your diet or whether you have surgery, that scar will not change back to muscle. So the point is to either try to prevent it, or if it occurs, to do it early enough to prevent it. Now, sometimes it's possible to have a major block, to have a heart attack, but there's enough blood supply to allow the muscle to be alive, but it can't pump very well. And that's when I think surgery sometimes is most beneficial, because we then bring new blood supply to that area. It's still alive, it doesn't pump very well, and afterwards the pump improves. I would like to make one comment about the diet. I think that's extraordinarily important. And I would like to have our viewers know that in last year in Lancet, which is an outstanding journal from England, there was an article in which a cardiologist from California named Ornish showed for the first time, to my satisfaction, that diet can reverse this disease to some degree. These were very advanced patients, and he put them on a prospective randomized study, did cardiac casts before the study, did them after the study, and in patients who could not have surgery, he showed that if you went on a vegetarian diet, 10% fat, very strict, no fish, no meat, no chicken, that after 1 year there was significant reversal in all the blocks in these patients. It didn't mean that the blocks went away, but in the comparative group, where they were on a standard diet, which is about 30% fat, their disease all progressed. So I think the cure is radical, whether you take balloon angioplasty or whether you have surgery, and the diet has to be radical too if you really hope to reverse it. But I think, as Dr. Hamzavi said, if you don't pay attention to this, then surely you'll be visiting one of us again.
And I think that, again, we get back into the preventative aspect as well. So if you've already been in once, you can do some things on the outside that don't have to be done by the surgeon on the inside. Just as we're getting to the very end of our program this morning, Dr. Wilcox, a lot of people always say, you know, well, I talked to my doctor and all I said was that, you know, I was having a little bit of pain, and all of a sudden I find myself in the emergency room hooked up to all sorts of instruments and things. That is a necessity, though, isn't it? That you know, when people think that maybe sometimes you overreact, but you're not really overreacting.
Well, it's better to be safe than sorry, and we have all these advanced diagnostic methods, and it's good to take precautions, and if the physician suspects that there may be a heart attack or angina pectoris, meaning which is a precursor, so to speak, to a heart attack. The faster one moves in that situation, the more likely the results are to be beneficial. As Dr. Cimochowski mentioned, if an artery on the surface of the heart becomes blocked, then you have a limited amount of time to intervene, to try to open that blockage and to prevent damage to the heart muscle. So, and we've all seen many examples of patients who neglected symptoms because they didn't want to believe they were related to the heart. Often patients will say, well, I have a little indigestion and so on. These are the kind of things that should be investigated by a physician, a cardiologist, to make sure that the heart is not involved.
Okay. Dr. Wilcox, thank you very much for joining us. Dr. Hamzavi and Dr. Cimochowski, our panel members this morning, as we were taking a look at the surgical aspects of heart disease. And we would like to remind you that coming up next week on Call the Doctor, our hour will be on burns. So we certainly hope that you will join us for that. I'm Paula Degnan, and thank you for joining us on Call the Doctor today. And we hope that you'll be back with us again next week.
Call the Doctor is made possible by